Hello, dear colleagues. My name is Paul Weigl, and I'm here in Dallas on the ICOI meeting to record for you this webinar. It's about an innovative site preparation and implant design. And I was working since more than 3 decades on the university in Frankfurt. It's called the Goethe University, named by a famous poet in Europe. And it was founded in 1914. And we are the second biggest faculty for medicine and also oral medicine. And this is the background. And the question is why we need an innovative site preparation. Is really necessary because we know if you place an implant in, mostly it healed in since more than 4 decades. However, there perhaps is an advantage, and this advantage can be for patients and of course for us too, or as clinicians. And going back to the patient's wishes, the main wish is, of course, they want to look nice, so natural looking aesthetics. However, they also want to have a minimal invasive interventions. And last not least, they want to have a time and cost efficient treatments. And this is the main motivation for the immediate loading and immediate restoration. Doesn't matter if it's on healed side or an extracted socket. They want to go not home with a gap. They want to go home with the tooth after the surgical intervention. Yeah, and with this immediate single implant restoration, we can use different implant systems. And the only one is that we need some primary stability. Therefore, the best is implant system, which has especially in the apical region, more or less a large thread design. We call it also progressive thread design or aggressive thread design, which is perfectly engaging in a soft bone in the apex of the socket. Okay, so the patient's wishes are minimal invasive intervention, especially also on the soft tissue side. So a punch combined with full guided treatment is the option sometimes if you have enough keratinized gingiva. And this means that the patients are very happy because there's less pain or no pain. I think it's nothing new for you. And this is, of course, a big advantage for the patients. It's based, on a treatment on a virtual patient. And then we can doing is on a real patient by stand or even by dynamic full guided restoration. What is the advantage here? You see the workflow immediate single implant restoration has compared to the analog conventional that we have a plan, then we place, then there's the impression, production, the abutment, temporary crown, insertion of the temporary crown. This is the daily business on a single. But today we have the digital full guided, and this is combined with a prefabricated abutment and temporary crown. That means you can make a crown and abutment ahead. And so you see the virtual treatment is followed by the real treatment, and therefore we don't need at the chair any more impression or production abutments or production of temporary crown. And this is very nice because it's very time efficient. So after placement of the implant, you have already the final abutment on the desk, and this is a big time gain. It's a reason that this kind of immediate loading and immediate restoration goes more and more as a familiar and very often used treatment concept combined with this special implant, macro designs, and so on. Here we see a case. There's a temporary crown, and then we have also seen that in some of the cases with this very minimal invasive protocol, we have a small gain of soft tissue. What you see here on one single case that we have a kind of creeping of the soft tissue into the coronal aspect 3 months later. Now we have to talk about this immediate loading, immediate restoration. There is a problem, and this is also mentioned in a lot of literature and also meta-analysis. We have a little bit higher early implant losses. That means that if you do not the delayed loading and you see, okay, this is a safe side, So you load the implant immediately, even we have a very good primary stability. The probability that you get lose an implant and the loss of an implant is a little bit higher. And this you see also in more or less latest literature. So that means here are meta-analysis showing that you have a little bit more early losses if you compare the delayed loading with the immediate loading and immediate placement. Okay, so we get now a little bit deeper in the reasons for that. And so if you look on the conventional osteotomy, this is a very famous graphic, but this is not based on numbers. It's only a didactical graphic. So be careful. And it's about 18 years old. However, very good to explain. So here you see the stability, so the anchoring quality. And this was scaled from 0 to 100. And here are the time. So it means if you place an implant, first it's very good stable, let me say 100%, and we call it prime stability. In other words, is the quality of a mechanical anchorage. But this anchorage going down and more or less to 0. Why? Because the bone surrounding your implant is more or less destroyed and resorbed. And then if you have only this curve, you will lose the implant. On the other hand, we have a new bone formation in the interface and very close to the surface of the implant. And this we call secondary stability. And fortunately, this is by time increasing the mechanical anchorage. And this is a stable and, of course, a very long-lasting and forever-lasting anchorage of the implant. So, and to have the sum of these two curves, this is, let me say, explained here. Once again, so you place an implant here into the bone. You see here in a scheme in the trabecular. And because of the heat and the water and all these things, you destroy the bone. And the reason is that this destroyed bone was eaten by the osteoclast and was remodeled by some fluid, and this we called death zone from Jill Helms. This is emergence around the implant leading to implant movement and probably implant loss. Because if this so-called death zone is too big, let me say more than 0.01 millimeter, the implant, if it's loaded, is then movable after 2-3 weeks, and then there's no chance that you have a osseointegration. In other words, if you have here a delayed loading and the death zone is too big, doesn't matter because the implant is not loaded. And that means this death zone is bridged by new bone. And because if there's no load, there's no movement. In case you have immediate loading, then you have a problem because the implant is loaded and therefore it's moved, micro movement, and there's no osseointegration. In consequence, any kind of implant you want to have an immediate loading, especially on singles, we cannot split to other implants. It's necessary to keep the death zone very, very small or even not. So this is a conventional osteotomy again. You have a resorption here, and here the mineralization of the new bone formation, and this is the sum, and you see after 2, 3, 4 weeks, you have a decrease in the mechanical anchoring quality. So it's a decrease in the stability of the implant, and then this decrease goes up again. So this is this kind of slump. Okay, and we have in Frankfurt University the same sometimes early losses, and you see we are very happy in this lower jaw that we placed the implant with a very strong torque, because 20 years ago and 15 years ago there was a rationale or a dogma. If you have high torque, it's good for immediate loading. You have a lot of better trust in it. But if you have more than 50, 60, if you're 100, sometimes the patient is coming after 2 or 3 weeks and they say, "Doctor, my crown is losing, and so you can remove the crown together with the implant because there's no osseointegration." And this is a typical example for early loss. And so the target is high primal stability. And you see a lot of companies want to have this kind of methods. They make an underdimensioned bone cavity, and the consequence is that you have a high pressure at the bone. That means if the diameter of the implant is the same like the diameter of the osteotomy, there's no pressure on the bone, and this we call it without misfit. But most of the companies recommend you to stop with the last burr for the osteotomy, which is a little bit smaller, and therefore you have a pressure on the bone, especially on the cortical, and this pressure will destroy the bone. And in consequence, you have a bigger, let me say, death zone. So for us, this is not a good method in case of immediate loading, especially for a single. Yeah, and therefore we follow this kind of paper from CHA, from the group from Jill Helms and Brunsky. It was published in Journal of Dental Research 8 years ago. And they have an animal model where they have no initial torque. That means this implant is not connecting to the bone in the cavity, so there is no primal stability. Then they have a low initial torque. That means only the tips of the threads are a little bit engaged in the residual bone of the cavity. And then they have high initial torque. That means this is an underdimensioned cavity with a diameter smaller than the diameter of the implant. So the whole thread and even the body of the implant is pressing against the bone. And these were the three groups they investigated. And then they make a histological evaluation with a histochemical staining of these preparates. And you see the green ones are the death cells, the cells which are not alive anymore. And the blue one are the alive. And you see with the high torque, you have much more death cells. So meaning this is the death zone, which is a little bit increased. And if you now go to this graphic from this paper, it's very impressive because with this staining, you can measure the layer of the death zone, the thickness of the layer. And you see, if the implant doesn't touch the bone, you still have destroyed bone, about 50 microns around the tissue, around the implant surface. If you have implant with a low torque, you see, it's not a lot, yeah. But if you have an implant with a high torque, the death zone, the layer of the death zone is more or less double or 3 times more. And this is a very nice proof of this kind of explanation that the underdimensioned diameter in the osteotomy is not a good recommendation because you create a big zone of cell death. And I show you here on the graphics again. Yeah, this is with implant low torque, and this is the death of zone with an implant with high torque, and this is the additional zone of death. In other words, the implant is a little bit more than the risk for early loss. Yeah. Okay. So you see, with the side preparation with underdimensioned cavities, we don't have this solution for the target for a safe osseointegration combined with the immediate loading for singles. So the requirements are clear. It should have a minimum damage of the bone because otherwise you get too much death zone around the implant. So we have to use a minimal invasive protocol. And we should also try that this death zone, even it's small, should be have a very fast growing of new bone. The new bone formations also should be really fast, that we have no risk for early losses, and it should be easy and safe to do in the clinical hands. Okay, so first of all, we try to have a minimal damage of the bone. And here again, so we hope from theoretical aspect, if we are minimal invasive, we should have less resorption. And if we are minimal invasive, perhaps the repair of the bone can be faster. And that is the reason that loss of stability is very zero or less. So this is the theoretical background, the motivation to do a little bit a new protocol and new tools for the site preparation. The first learning curve we have more than 2 decades ago was the idea that the last drill should always be super sharp. So we recommend that the last drill should be always new. Even it's a little bit more costly for the therapy costs. You save money on the wrong side if you use if you reuse the burr very often, especially the last one, because otherwise, if it's not super sharp, you get the overheating of the bone, and therefore you get a little bit higher death zone. And therefore, we want to have a super sharp drill in the last one, and it should be not high speeded, it should be low speeded if it's possible. Low speeded means about 800 repetition per minute or 700, not 2000. Some implant companies recognize this and know this about the death zone. So here you have an example that we have implant system with a co-packed last drill. So the last drill you have to use is not in your kit, in your surgical kit. It's in the package of the implant. And because it's always new and is not reused anymore, this is super sharp. This is an idea of a co-packed drill. And yeah, this is also a solution for this reducing of the early losses. Next point is, if you have a lot of burrs, yeah, that we have, of course, a lot of trauma for the burr, for the bone, and I think it's clear without to have evidence that if you use a lot of burrs, you hurt the bone and you damage the bone a little bit more. Then you have only 2 super sharp drills if you compare to 7, 8 drills sometimes you use in other systems. Okay, so this was now the start point to develop a new innovative site preparation. And the first is, if you make a lot of immediate placement in a socket, you have experience that the pilot drill, the first drill, is not very often going very nicely into the cortical bone of the socket. And this is not a problem, because if you do it freehand, you can make a tilted burr and then you tilted the burr later. But especially in the guided with a template, you have sometimes a problem because the burr is not engaging in the bone. So what we do is we reorganize and re-engineering the tip of the burr. And for this, we have a better behavior in this special situation. Normally, a pilot drill, if you have this steep angulation, it slips away, yeah, and it slides away, especially in the guided burr. And if you have now the special tip, it's very easy to go in because the burr is engaging nicely also in this situation. Because, you know, mostly you should place an implant in the socket, especially in the aesthetic zone in the upper jaw, a little bit more orderly and not exactly in the center for many reasons. So then the next is, we want to have a smart osteotomy tool working different for soft and dense bone, and I will explain. And this is meaning, this is the burr that goes very slowly into the socket or into the heel side, doesn't matter. It's super sharp because the cutting fluids are always new. So it's a single-use burr, yeah, and you insert this burr more or less in the same velocity, so 25, 30, 40 repetition per minute, so very slow, like an implant. It means that you don't need cooling with water. So in the video, you see, okay, nothing special. Because there's no water and high speed, there's also very convenient for the patient because there's no noise anymore. And next is because it's so slowly rotating, if you compare it with a real-time conventional drill, here you see infrared camera, infrared video camera, which is seeing the heat propagation very nicely. And you see, you get here a high temperature, And if you do this with a low speeded special tool, which we call OsseoShaper, you get not so high temperature. So there's a next big point that slowly rotating special tool, super sharp, is not overheating your bone in a such extent than a high-speed drill. Good. So the advantage for patients we now know is, first, it's not so loud, it's not so noisy, and we can work without water. And there's also no vibration. But this is not the issue that we use this burr. For clinicians, we have much more advantages. You can have a clear view. That's the first point. It's a stress field control, because you will see that the burr is exactly following the site preparation of the first pilot drill. And it's a time saving, because this is mostly the last burr after the pilot drill. So you have only two in more than 80% of the cases, or you start with the pilot drill, and then you use this special burr, and then you can go for the implant insertion. So it's a very time-saving protocol. And the main core advantage is that this tool is managing the bone quality. What is managing the bone quality? I think everybody is clear. The cortical bone is a hard bone, and it should be cutted off that the implant can go in smoothly. Because if you don't cut the cortical bone, the implant insertion will not work, because it stucks or you get a too high torque. But the soft bone, it should not be removed. It should all be only condensed if it's possible. So this tool should do both, cutting hard bone and condensing soft bone. This was a target for the engineering. And therefore the engineers saying, okay, all the burrs we use the last 50 years for bone osteotomy, they are, let me say, coming from the world out of the mouse. So we use the same burr like we make a hole in a piece of wood or a piece of concrete or in glass or steel. So these are conventional burrs. But this burr is specially designed for bone in the old cavity. So for the alveolar ridge, for the socket. This is a special, let me say, development for our material. And our material is a vital bone in the alveolar ridge. And therefore, if you look on the burr in a cross section, it's not round, it's a triangle. That means a tri-oval burr, meaning that the diameter is not the same. On some points, you have the maxima here and here and here. And in some points, you have less diameter. And therefore, we call it tri-oval, because it's inside a triangle. Why tri-oval? This animation shows you that if you have a round burr, and this is the bone, brown thing is the bone, and this is the round burr. The round burr has cutting flutes, meaning cutting away the bone here. And if you have now a rotation, you see the cutting flutes are always in the same distance to the bone. So they cut the bone in the same distance. Nothing special. 99% of the burrs are working with this kind of cutting flutes. If you have now a tri-oval burr, you have maximas of the diameter and minimas of the diameter. So if you rotate now this tri-oval burr, you see the distance to the bone is changing. Sometimes it's far away, and sometimes it's very close. You see? Okay, this is the dynamic of a tri-oval burr. And now you can place the cutting flute, which is cutting, more or less after the maxima. So after the maxima, the cutting flute is positioned. And now you will understand immediately why this burr is working in another mode than the conventional round burrs. If you have a tri-oval tool, yeah, with a cutting fluid immediately after the maximum. And this is contacting a cortical bone. The cortical bone will a little bit pressed out, very small, yeah. So this is a little bit pressing out the cortical bone. Let me say 0.01 millimeter, 0.01 millimeter, really a little bit. However, after the burr is rotating and it has his small diameter, yeah, the cortical bone is immediately coming back, because you have here a rebound effect. This is the same like you push your hand in a thin metal, yeah, and if this metal is a little bit bended and you remove your hand, the metal is coming back. This we call rebound effect, and this is with a stiff material like cortical bone, very fast, yeah. So let me say, if you place now after the maximum the cutting fluid can cut the bone because the bone is immediately coming back. And now you will guess what happens if you have spongious bone. With a spongious bone, you have the same. The maximum is pressing the spongious bone away, yeah. And then the tool is rotating a little bit more, but the spongious bone, if you press away, it's coming not back because you condensate the bone. And if you condensate the spongious bone with this trabecula, it's not coming back. And because it's not coming back so fast or never coming back, the cutting fluid after the maxima cannot cut anymore. And now you have an idle situation. The spongious bone with this tool is not cutted, only condensed. And the cortical bone is with the same tool cutted because it can't be condensed. And therefore you have a tool which is different. Make their own decision. This is a hard bone you have to cut, and this is a spongious bone I only have to condense. But it's not done by you, it's done by the tool. So we have a more or less smart tool for this osteotomy protocol. Okay, so because it's come not perfectly back, we have a condensation. And so as a result, what we see is this tool is cutting solely hard bone and more or less no soft bone, more or less only condensing. Yeah, this is the new feature of this tool. And to understand better what kind of advantage from the bone is coming, I used this kind of drawings. If you go with a high-speed drill into the bone, it's impossible to cool perfectly. So you see with this red coloring that you overheat the bone and it's not perfectly. So you create some kind of death zone, yeah, because the temperature go over 47, even with the cooling. Yeah, the water cooling reduce only the temperature here and there, yeah, on the top, but not in the deep area. And next is with a high-speed drill, you have a must for cooling. You can't use a high-speed drill without cooling. It's a crime and nobody do it, fortunately. However, this must of cooling with water or ringer solution water with some salt that you don't have osmotic pressure. Yeah? All this blood and bone chips and vital cells are washed out. So in the end, you wash out this bone cavity, and in the end, you have only more or less the structure of the trabecula, but the blood and all the bone morphology, proteins, and so on going out. And so this is a starting point for placing the implant. And this was investigated in this paper from Chan, published 4 years ago, a novel osteotomy preparation technique to preserve implant site viability and enhance osteogenesis. And we started the group with Jill Helms. I was also integrated with a rat model first. Then we go to a bigger animal, the mini pig, and of course later we go for a clinic trial, of course, without any histological evaluations. But this is mirroring the control group. So this is a conventional protocol, and these are the picture what you have kind of osteotomy sites after the conventional protocol with round burrs and water cooling. If you now compare this protocol with the special tool, and this special tool is going in very slowly, less than 50 repetitions per minute. Therefore, we create very small temperature. So there's no need for cooling with the water. And because we not have any water cooling, all of these ingredients in the socket, the blood, the bone chips, everything stays in the socket, stays in the osteotomy site. And you have complete other kind of osteotomy and starting point for osseointegration. Yeah, because it's a textured bone cavity for improved osseointegration, and this is showing about this paper. Because if you use now this OsseoShaper or this new tool, you see this is not perfect round, because of this special cutting and condensing. The osteotomy has in the entrance, let me say, a not smooth line. It's a little bit smaller, bigger here. And the same in the human, it's not a perfect cutted. And we cannot see, but there's a lot of more blood and bone chips in this site. Okay, so these are, again, the control group with the conventional protocol compared with the new tool on the same animals in a split mouse design. And of course, in the animal studies, here on the mini pig, there can also be making histological slices. And what you see here, you have a very sharp cutting with a round burr. This is the bone, and this is the cavity. But after some weeks, we have no bone formation. This is starting very slowly. If you now compare this with the OsseoShaper, you see it's not a perfect cutted line. So perhaps this is the cutting line, but the cutting line is also full of bone debris, blood, and bone chips and so on. You see it also here. That means this is also big differences in this site. But surprise, surprise, and this is the best result ever. With the split mouse design, you see after 1 week much more bone formation, because the bone chips and the remaining blood, because it's not blowed out with a water rinsing, this can create new bone faster compared to the conventional protocol. And once again, this is only helpful for immediate loading. If you stay on delayed loading in a submerged healing mode, you can wait some weeks more that the new bone formation will coming, and they will come. That's the reason that we are working with implants more than 50 years. But this means that the new bone formation is accelerated, because the new bone formation is starting from the old bone chips, which are not removed, which are staying in. Okay, so we have now an accelerated new bone formation. And this is a very nice protocol, because you see, you have the pilot drill, then this special triangle-shaped tool, which is always super sharp. And then in the end, you can place the implant. This is the idea. And in 90%, 80% depends on the clinician and the patient selections, of course. But let me say 85%, you can use this protocol, so you have less burrs and therefore less trauma for placing an implant. In 10 remaining percent, you have a second tool, and this second tool is a little wider in diameter and has more cutting fluid, so it's more aggressive cutting. Because if you have a super hard bone like D1 bone quality, which is more or less only cortical bone, this burr is too weak to go in. So you need a second one. This is the point. And the protocol thinks, okay, if you have more torque necessity, more than 40 Newton centimeter that is going down, you should go for that. So this is the protocol, what is depending on this special OsseoShaper protocol. Now, about the usability and easiness to realize it. So typical case, we have to extract this fractured tooth, which has also some periapical lesions, you see, so we cannot keep him. There's a more or less hopeless situation. We do, of course, a minimal invasive extraction without a flap. And then you come first with the pilot drill. Yeah, the pilot drill is with water. It's making the osteotomy preparation, the beginning. And after this pilot drill, which is not slipping, what we see before, we go in with this special burr. This is called OsseoShaper, which is triangled. And because it goes so slowly into this side, we don't need a water. And especially in the upper jaw, you never use a second OsseoShaper. It's only in the lower jaw because there's sometimes more D1 bone quality. Okay, so however, the cuts must always be sharp, otherwise this burr is not working in this way I show you. Therefore, the company is deciding that we have to use a single-use tool, and this is, of course, a little bit debate because clinicians doesn't like to throw away a burr after one use. Of course, you can use it twice or three times in the same patient if you place 3 implants. But if you place the implants, you have also 3 burrs because they are co-packed. Yeah, so the OsseoShaper and the implant are co-packed. Yeah, and this is also nice because you see the length of the tool and the taper of the tool and the implant is more or less the same. That means you cannot make any mistake. You have a very good orientation. Also, if you go crestally or subcrestally, this burr is shaping more or less exactly the shape for the osteotomy, for the implant you place after the osteotomy. So, and therefore you have this package, and in this package, first you remove the implant out. Yeah, so you have, first you remove the OsseoShaper out, sorry. And after you do the osteotomy, you have in the same package on the other side the implant, which has the same diameter, the same length, and the same taper. So this is a typical co-packed situation. Yeah, this nice video coming from Giacomo Fabri. Okay, so this is a protocol for the co-packing. And now you see the placement of the implant is more or less the same velocity. The only difference is you don't have to remove it. You stayed in because OsseoShaper you remove, of course, again. And here you bring in the implant and also without water. So it's a very minimal invasive protocol and workflow for the bone. Yeah, and then you place temporary here, the original tooth, which was realigned in a non-functional occlusion, of course, never splinted to the neighboring teeth so that the healing can start. Here, very uneventful healing. The problem is here because we use the original tooth, the patient is not willing to replace it on a crown because it looks, of course, nature-like. So this is another point. Good. So let me say the innovative site preparation, the mission is completed because we have minimal damage of the bone. We have accelerated new bone formation and it's easier and safe to do. So I think this site preparation can be a start in a new area for osteotomy because we have a tool and a protocol which is not developed to make holes in wood or in concrete or in glass or steel with conventional burrs. So it's a protocol which is based on a special developed burr and tool for the bone. And now the implant has the same idea. It's in the apex round, so there's no difference, but on the coronal part on the platform, it's also trioval shaped. Yeah. And this trioval shape is also giving a very nice option that the cortical bone is never pressed or overloaded. So you're seeing some resorption of the bone. Yeah. Okay, here you see also that stability is the same because the stability of these implants coming from the lower part of this implant. If you go for this paper from the mechanical and biological advantages of a trioval implant design, they make also this histological investigations, and they compare it between the control group, the round implants, and now the trioval implants, and they have a better lateral stability, both immediately and over the time, the trioval, and it has a smaller zone of death, and they have also a higher cell viability. So the trioval design is also very interesting for this death zone, because the death zone is not so strong established than with a round implant. We don't exactly understand why, but we think that only the maximus who are in contact to the cortical bone and even to the spongious bone can hurt the bone. The gaps are filled with blood. There's no pressure, and the blood is more or less in the closed room and space and can react to be the new bone. So this is the idea of this trioval shape of the of this, and this was also realized by the MIS implants with the V3. Okay, so for patients, we have this advantage that we have a little bit more bone, especially in the buccal aspect. It's not a lot, perhaps 0.2 millimeter, but during the aging, so the patients get 15, 20 years older, we have a remodeling of the bone, independent of there is an implant placed or not, that in the upper jaw, we have some bone resorption on the buccal side of the alveolar ridge. And if we have a little bit more bone, so you can a little bit postpone this fate that implant can have demasking or a recession here. So this is a little bit too more bones. Therefore, the implant has always, let me say, orientated that the flat side is orientated onto the buccal side. You see here the trioval shaped implant and the implant driver. The implant driver is not connecting. The implant is connecting only the internal hex. Okay, now we come to the indexing of the abutment. So normally you have an index in the platform of the implant. It has thousands of different designs. You have an internal hex or an octagon. You have only one position. You have 3 lobes and so on. But here we have a fusion of the index and cone, because what we do is we follow the trioval shape of the implant, and we design a trioval shaped cone. And the trioval shaped cone is not round, it's trioval, and therefore you cannot rotate. So you have more or less integrated index, which is locking against rotation movements and can transfer the abutment in the right position from the master cast into the patient's mouth. So there's nothing new. The advantage is here that we have a self-centering mechanism. So if you bring in the abutment is rotating in the final position, in the final rotational position alone, because it's only 3. So this is a big advantage, because you don't need these transfer keys anymore. And especially if you have an implant and you restore it with an abutment in the posterior region, in the molar region, it's very difficult to see in the upper jaw. So you go only in with the implant or the abutment crown, and it's rotating for alone. It's a self-centering procedure. This is also very easy to use and helping every day a little bit faster and safer to place abutments with an index. We have also here some own experiences with the pre-launch, because we are in the team where we created this implant. Now, last not least, I want to say something between the ICOI and the Goethe University. We run now more than 7 years, a very nice working cooperation, because we have this postgraduate program. We called it Master of Science in Oral Implantology, in the abbreviation MOI. And the ICOI doing a lot of education, continued education, postgraduate education. And these two, let me say, words can have a good combination, because both are non-profit. Yeah, so both organizations, the State University in Frankfurt and the ICOI, works non-profit. Therefore, there's no bias in the content what we teach. And later is also that we have international course that we go for a lot of countries, and ICOI is also global working. So therefore, both have education-driven vision and mission, and we try to provide you with the highest quality of standards. And of course, we are working internationally. And because of this is very nice together. We have here, I think, a good success. Okay, it was a little bit downsized in the time of the pandemic with COVID, but now it's more or less coming back to the normal situation. So we are starting 15 years ago and 14 years ago, and we have more than 800 students now from 82 nations. And you see here on the dark blue, all over the world, our students are coming to Frankfurt. So hopefully you too soon. A little bit about the protocol of the Master of Science of Oral Implantology. It's a part-time master. So after 2 years, we have here the ceremony. It's non-sponsored by none of any company, non-association. It's completely only getting the annual fees from you, from the students, and therefore we are completely unbiased. So you can use every implant system you use in your office. You can use every membrane and bone substitutes. We don't care, as long as it is certificated and has a clearance to FDA or MDR or your local authorities, that you can use it on a patient. And this is scientific based. That means we rely on evidence, and we recommend papers and following this new data. And we know, because we are academics, the knowledge of yesterday can be the error of today. And the other way, the knowledge what I tell you today can be the error of tomorrow. And of course, oral implantology is a multidisciplinary approach. So the program is not containing only surgery and implant placement. There's also perio, ortho, prosto, dental labs, and so on. And so this is, very often. Okay, so good. Here's a little bit the setup, because we change between so-called homework time. So you be at home, like in the COVID time, in the pandemic, and you have Zoom or Teams, and we track you, we monitor you, you do all the jobs at home. And 4 times a year, you have to travel to Frankfurt, but you have an international airport. Most of the connections are without having a stopover. So most of them, they are direct. And you are here for 10, 12 days. And so you have hands-on and we have lectures. And here you see, this is twice a year. And the rest of your time in the 2 year, you have to learn at home by e-learning. And I think you do it now also, if you look on my webinar. It is very convenient, because you can run your office, and you can do this in the evening or in the weekend and so on. You can do it when it wants, but you have to do it. So if you join this program, I can tell you minimum 1 day a week, you should do something for the program. Otherwise, you come in a trouble, and it's a reason that most of the students are not ready or finished after 2 years, so they take a little bit longer, okay, but doesn't matter. But it enables that you not shut down your office 2 years with a full-time master, and you can run it, and you don't have to leave your country or your family or your kids and so on. So you're more present, yeah. And this is, I think, the biggest advantage, that more students can do a Master of Science. And this is, I think, very interesting, this format. Okay, these are my contact details. If you are interested in this program, you can go for an email directly to me, or you go on the websites or on Facebook, where all the details are, let me say, explained. But of course, if you really want to submit and enroll in the program, we have always an interview with you. It takes about a half hour, a personal interview, and sometimes we also say, okay, makes no sense, make first a little bit more implants, because we are non-profit, so we are not interested to have a lot of students. We want that you get a really good 2 years, and so sometimes students come too early in the program, so you should minimum place 20, 30, 50 implants or restore a lot, because it's not a starter program. Okay, thank you very much for your attention, and have a nice day or evening at what time you watch this webinar. And if you have any questions, don't hesitate to contact me via email. Thank you very much.